Good afternoon, everyone, and thank you for attending today's webinar, Medicare's Annual Wellness Visit, a Framework for Quality Patient Care, presented by Mark Sapner, VP of Product and Program Compliance, and Bob Chittenden, VP of Sales and Partnerships of CarePoint MD. Mark and Bob are also the co-founders of CarePoint MD, and Mark will be your primary presenter today. Please be aware that there will be a question and answer portion at the end of today's webinar. Please type your questions in the question box located on the right of your screen. They will be answered in the order received. Additionally, if you would like a copy of the presentation slides to keep or to print out and take notes on during today's webinar, please find them on the right of your screen in the handout section. They will also be emailed to all participants following the completion of today's webinar, as well as the recorded version will also be available on the website for members only. Again, we would like to thank you for attending, and I will now turn things over to Mark and Bob.
Thank you, Bree. I just want to confirm, Bree, that you can see the next slide and we'll get started. Okay, great. So Bob and myself, we're from CarePoint MD. We're an organization that focuses on helping to deliver value-based preventative care solutions for Medicare and Medicare Advantage plans. We work with small and large organizations. We use the annual wellness visit as a framework and a foundation to deliver those services. So the information that we're going to convey today is going to be in that context. The normal disclaimer, the information in this presentation is a general summary. Much of it is illustrative in nature. I tried to provide sources and references where relevant, but I think the point is that this is high level and is intended to give a very wide understanding and spectrum of the preventative service programs from Medicare, including the annual wellness visit, and allow you to dig deeper in individual topics with the sources and references on each slide. So our primary goal is to promote the use of the annual wellness visit and the associated preventative services from Medicare. I expect that you joined today because you're either looking to start providing similar services or improve how you're delivering them today. So there's a couple of objectives that we've outlined. The first is to understand what the annual wellness visit is and its value. The second is how it addresses age-related issues for the elderly population, improve population health. It can drive and really does support coordination of care activities. That directly translates to Medicare's measured incentive payment system quality reporting requirements. Many of the outcomes from the annual wellness visit directly support that program. And then we'll go through some options and methods and some resources that you can use to implement a successful AWV strategy, which would not only help improve overall patient care, but also help drive new practice revenue. So at the core, Medicare's annual wellness visit is a bit different than the typical physical exam from commercial insurers that you'd see prior to a patient joining Medicare. The focus is less about a review of body systems and including ordering of lab work, and it's more focused on the current health of the patient, creating a plan for them to address staying healthy. There's a strong focus on screening for risks and counseling, interventions, referrals, as well as social and behavioral items, lifestyle solutions that can be helped to identified and addressed. So when we get into it, there are essentially three different types of AWVs. They're fairly similar, but they have a different context and use depending on where the patient is in their Medicare life cycle. So the first version is an initial preventative physical exam, or an IPPE, which is the welcome to Medicare visit. It is a once in a lifetime benefit. It is only available to be provided in the very first 12 months of Part B coverage. So that may be when the patient turns 65, but it could also be at a different age if that is within the first 12 months that they're joining Medicare. That reimbursement, if you look at the bottom, is about $170 nationally. I think most of the people on the call here are in New Jersey. So generally speaking, New Jersey's got higher reimbursement rates than the national average. And where we reference reimbursement rates for particular procedures or services, I'm going to use the New Jersey average. The second is the initial annual wellness visit. And this is the very first time after the initial 12 months that a patient has an annual wellness visit. So it doesn't necessarily preclude the patient from having or have not had the initial preventative physical exam. If a patient missed that IPPE in the first 12 months, they would go right to the initial annual wellness visit and start there. The requirements are a little bit different. We'll go through them after. The reimbursement is nearly the same, and the relative value units are identical. Following that very initial wellness visit, where the requirements are a little bit more comprehensive, every wellness visit thereafter, which is annually, is going to be a subsequent annual wellness visit. And we're going to go through those differences, but essentially a year has to pass from each annual wellness visit before the patient is eligible for the next one. And they're only eligible to receive an annual wellness visit from one provider during that period. That means that if another provider gave them an annual wellness visit, you'd have to wait until they were eligible again before you were able to give it to them. And it's not necessarily limited to just primary care providers, though that is the intended setting. We'll go through that also. I want to point out right where you see at the bottom, source, typically that's where I'm going to put the references. They should be clickable in the file that Bree sent out. If not, you can copy them and put them into a web browser. Often cases, if they're a PDF, it's not going to be a web page. You're just going to get the PDF viewed or downloaded, and then you can refer to that. So we talked a little bit about the requirements for which AWV is appropriate. Because it's not always a specific age scenario, you don't necessarily know the first 12 months that a patient joined Medicare. Also, you don't know if they've had their initial yet or not, and they could be in their 70s and have never received an AWV, and so you're going to deliver an initial. There are really only two ways to determine which is the appropriate one. The first is you can call the MAC carrier for our area, which is Novitas, by telephone. Typically, it's an IVR system. They'll ask for the NPI, the P10 number, I believe the tax ID. They're going to ask for the subscriber number of the Medicare patient. They're going to ask you to either spell or speak the last name of the patient, and then they're going to ask for what code you're inquiring about, and the automated system will tell you whether or not the person is eligible for that code or not. So typically, if you know that they have not just joined Medicare, you can ask for code G0438, which is the initial. And if they're not eligible for that, then you know that they're going to be eligible at a certain time for the subsequent, which is the G0439. There is an electronic option. If you haven't signed up for this already, I would strongly encourage you to. It's a lot easier and faster than using the phone, which is the HIPAA eligibility transaction system. It's a CMS-run site with a login, and after registering, you can use a web browser to get the same type of eligibility information back. So we talked a little bit about who can provide the annual wellness visit, and Medicare gives some guidelines around who can. They're not so clear on who can't and where you can't, but they are clear on who can and when you can. And this may be an area that we can discuss in the questions and answers section if there's any specific concerns. We've had a lot of dealings with different types of providers doing the AWV as well as different settings. So specifically, any MD or DO can provide the AWV, as well as other non-physician practitioners. So that would be somebody like an NP or a PA or a certified clinical nurse specialist. Additionally, most of the AWV, at least in normal settings, can be provided by other medical professionals that are on the provider's team, as long as they are directly supervised. That's not applicable to the IPP. That must be provided by a physician or an NPP, but the initial and the subsequents can. I wrote down here what direct supervision means for Medicare, so that if there's any question, we can go look and see, are you meeting that requirement? So one good example is, can an MA in your office provide the annual wellness visit? And the answer is yes, as long as there is a physician in the office on site that can step in and provide direction if required. Medicare also specifies where they're looking for annual wellness visits to be provided, and that is typically in a primary care setting. So definitely in a physician office or physician-based clinic, as well as all of the other health centers, including hospital inpatient and outpatient facilities and critical access hospitals. They do have some areas that they specifically say not to provide it in. And so we can go through that if anybody cares at the end of the presentation. So one question that we get, which I'll just hit on, is typically, can an internist like a cardiologist perform an AWV? And a cardiologist is certainly going to be a physician. And then we get into the question of, is their practice run such that they can support an annual wellness visit? So that means that, do they see the patient on a regular basis, meaning at least once a year? Do they have a scope of practice that they're capable following up on things like overdue immunizations, vaccines, boosters, and can they schedule screenings, and are they able to identify, counsel, and refer out where needed? And if the answer is yes to those questions, from the practice's perspective and the documentation as coding is done correctly, yes, a cardiologist can deliver it. However, if you're not able to say yes to those typical questions, that's a very gray area, and I think the recommendation is generally to let a traditional primary care provider deliver the annual wellness visit and stay away from it. Just one point of note that's often overlooked is that gynecology for women's health is absolutely considered primary care, not even a question, and it's strongly encouraged for those types of practices to support annual wellness visits where they're able to. So diving a little bit deeper into the details of an annual wellness visit, I've got some little asterisks here that indicate which components are just for the very first Welcome to Medicare visit and the initial, and then those which are subject to just the initial and any subsequent annual wellness visits. Anything that doesn't have an asterisk next to one of the letters is applicable to both the initial and the subsequent, as well as the Welcome to Medicare. I just want to point out that the second point under letter I is individually marked as this is just the initial and subsequent, but the first point under letter I is applicable to all of them. So first and foremost, we're looking to deliver a health risk assessment. The health risk assessment is traditionally a question and answer form that is delivered or captured from the patient, and it collects information on their overall well-being and how well their health is doing, as well as any behavioral items or risks that could come up. And that's really the basis for how we are calculating the outcomes of the rest of the annual wellness visit. So part of that should include medical, family, and social history. Social history is not something which is always taken, but it is a compliant requirement for annual wellness visit. So at a minimum, that goes to diet, exercise, alcohol, tobacco, drug use. Fall risk is separate, but you'll notice on the social history side, the items that are called out explicitly also directly drive population health requirements. That's not by accident. We'll talk more about that in a little bit. The only touch point for the annual wellness visit is to capture some vitals. Height, weight, body mass, which is calculated by height and weight, and blood pressure. Visual acuity screen is also required, but only for the very first Welcome to Medicare visit, so that's during the first 12 months of a beneficiary joining Medicare. Medications and supplements should be documented fully, not just what kind they are, but which ones, what's the dose, what's the frequency, and then specifically which supplements and also dose and frequency. Review risk factors for depression. The easiest way to do that is through standardized testing tools like a PHQ-9 to go through a depression assessment. We're going to review functional ability and level of safety, and other providers and medical equipment manufacturers that the patient regularly is involved with in getting and providing their ongoing medical care. Detection of cognitive impairment. You'll see now we're getting into the current providers and cognitive impairment. So this is where the initial and subsequent annual wellness visits have a little bit more comprehensive requirement than the Welcome to Medicare. A written screening schedule for the next 5 to 10 years needs to be created. And additionally, during that health risk assessment, when we're looking at the answers and how the patient responded to that, compiling a list of risk factors and conditions which may affect mental and behavioral health so that we can really identify potential treatment and intervention options associated with the risks that they're encountering. And we've got some examples of that as we get further along. Last, rounding this out is to give some advice and referrals for health education and preventive counseling services, specifically self-help, managed resources, community-based lifestyle interventions. Medicare really likes to do this through pamphlets and brochures. They have lots of them on their website. NIA, National Institute of Aging, has a lot of these on their website. They are also happy to package them up and ship them to you for free, including they pay for shipping, so that these brochures and small action plans can be handed out to patients. And the last component is advanced care planning. So this is really around advanced directives, legal documents where future care decisions that the patient has wishes for can be made if they're not able to speak for themselves. Typically, this was in the form of POLST and MOLST or DNR, maybe 10 or longer years ago. Medicare has kind of given guidance now that they're looking for a POLST or MOLST only to be delivered, and POLST is New Jersey. Some other states use medical orders instead of physician orders, just naming convention, really. Only where there is imminent health issues where end of life is likely or near. What they're looking for in all other cases is to use an advanced directive. That's a simple form that the patient can fill out with family and designate a healthcare proxy. They can sign that in their own home and fill it out and bring it back, and it's a legal document. So the title of the presentation was a framework for quality patient care. And so what we want to do is just define what does quality patient care mean in the context of the annual wellness visit and what we're talking about. And specifically, it's value-based programs aligned with Medicare's preventative services program. Medicare's got a very good website. It's interactive. The link's there at the bottom. We can go in and drill down on any of those squares, and they move around and give you a lot of good information. They also have a PDF version that you can download of those. But these are the items that Medicare has determined they're looking to concentrate on. They're mainly taken from the U.S. Service Preventative Task Force, grade A and B recommendations, in addition to recommendations on immunizations. So the second question is, what do we mean by framework? And that little matrix of boxes, if we go back, you'll notice that Medicare organizes it alphabetically. And it's very difficult when you just look at this to determine where to start and what constitutes medical necessity and what constitutes risk, and how you get from determining what should be delivered when. The annual wellness visit is the answer to that. It is a framework which should be delivered first, and it's comprehensive, meaning that the outcome of that should drive identifying and recommending delivery of any of those preventative services that were outlined on their website. So this is just a different graphic of them with generic names that is kind of put together in the way that they're viewed from an annual wellness visit perspective. And if you're thinking about quality care delivery and improving patient care, the annual wellness visit is based on some expectations that you've got to buy into. And the first is that the identification and delivery of preventative service is going to be comprehensive, and you're going to be able to at least identify any of those services that Medicare has identified as high priority. We need to believe that the increased use of those preventative services actually translates into improved health outcomes, including reduced spending, which has been a major one of the major priorities in pushing the annual wellness visit. As I said, it's mainly based on the U.S. Preventative Service Task Force A and B recommendations, and that also the delivery rate of the annual wellness visit to individual providers' patient populations is going to be meaningful enough to exceed a threshold where you're going to hit a good portion of the population to make a difference. One of the ways, there's really three ways that they're looking to push that. So they're trying to create an efficient mechanism for you to deliver the services, make it cost effective, meaning there's good reimbursement for it, and cost effective for patients, meaning they've waived the co-insurance and deductible aspects of all the preventative care services. There are also fairly substantial ancillary benefits that we'll talk about. The third that's not listed here really is that it's driving the measured incentive payment system quality metrics. The AWV supports a good number of them, and that's an additional benefit to try to gain acceptance and delivery of the annual wellness visit. So when we look back at that matrix of preventative services, which is in alphabetical order, really what we can think about it is as providing an annual wellness visit first, and then structuring that wellness visit so that we identify groups of things that a patient would be applicable for. So I put some examples down here. It's not comprehensive, but I think that these are probably the most typical that you're going to hit. And across the board, driving coordination of care and then quality reporting, as we said. You're going to see this graphic again as we go through an example. But I think the point here is to convey that it doesn't have to be confusing, and there's value that can be delivered in a systematic and organized manner, which can be implemented fairly easily. So the benefits to the patient are fairly numerous. One of the things that typically we skip over or don't think about is the fact that this actually strengthens the relationship between you and the patient. Typically, patients only come in, they're complaining about something. It's a fee-for-service symptomatic visit evaluation and management code. You're treating something, and typically they're coming back when they need to follow up on that. There's usually not a lot of time in primary care to sit down and talk to patients about how well they're doing and some of the ancillary things that we pick up in a health risk assessment part of the annual wellness visit. And we find that patients especially enjoy that and appreciate it, as well as the fact that, as we'll see, there is value in reducing cost and improving quality of the care delivered for the patient. There's also benefits to the practice. Improving patient care is obviously at the top of the list. It does drive down costs. It allows you to have a more complete picture of the patient, increases their engagement, and there's also new revenue opportunity, which we'll get to, because that's a big part and it's important. Starting in 2011, the annual wellness visit was made available by Medicare. It wasn't up until just a few years ago that we started seeing studies tie use of the annual wellness visit and the delivered preventative services to actual improved healthcare quality and cost reduction. We're starting to see some of those studies come out now. I put a few slides in here that just indicate over some studies, we do have cost reduction long term. You do have higher screening rates, which then leads to risk identification and counseling referral where needed. I put one specific or potentially two specific studies in for original Medicare fee-for-service that goes through some of those outcomes, and then as well a Medicare Advantage study that was performed. You'll see at the bottom of all these slides is the source for the links of where the studies are, so you can dig further into them if it's of interest to you. So we talked a little bit about care coordination, tying a lot of the derivative preventative services that come out of the annual wellness visit together. And Medicare in particular identifies 4 areas of care coordination that they want to concentrate on delivering. They do include advanced care planning as one of those care coordination items. Obviously, the advanced directive is not only to be used within the physician's practice, but has its value in its use outside of the practice. So that's the first. Transitional care management. I'm just going to go through these at a level on this page. I've got a slide for each of them that goes into some more detail. We can cover briefly just some of the requirements and reimbursements, but these are fairly well-established programs that you can do on your own that have fairly good reimbursements. And then the nice thing is you also have the opportunity to partner with industry vendors who do this fairly well. And my recommendation is if you're already doing it, continue to do it. And if you're just starting out, consider partnering with somebody, get references, talk to some of the other providers that are using them. So transitional care management is really to address the handoff of the period when a patient leaves a hospital and goes into what Medicare calls their community setting, but really that's just their home or their normal living situation. And it does require that a primary care provider follow them and try to do a coordination of care over the 30 days following the discharge. Chronic care management has both a standard and a complex scenario. It's really where we're looking to address chronic illnesses that a patient has with some action plans, and then provide monthly follow-up to help track and improve their adherence to those action plans, and then also identify where they're not improving. We can highlight that maybe the action plan needs to be changed. And then very similar to CCM is the behavioral health, except on the instead of being on the chronic condition side, it's on the mental or behavioral health side. But it's got very similar requirements where it's monthly follow-up. There's action plans. Where there's more serious behavioral or mental issues, there's a more complex option, which includes integrating psychiatric care. So that would be a specialist, and that was called collaborative care services. But it's still under the same behavioral health integration set of codes. The requirements are obviously more comprehensive for complex CCM, and then collaborative care services for BHI. So as I said, each of these 4 has a separate reference slide just to go through who can bill them, some of the important things to keep mind about if you're going to be providing the services. All 4 of the care coordination services are encouraged to be provided. I wouldn't recommend starting them all at once. If you're just starting out, get the AWV down first, and then we can look at turning these things on one by one as your maturity and efficiency in delivering services improves. So advanced care planning can be billed by physicians, non-physician practitioners. It can also be billed by other people on the team, meaning if somebody's into your office and let's say your MA is delivering the annual wellness visit, they can also deliver the advanced care planning. So it's applicable to everybody. If it's delivered with the annual wellness visit, there is no coinsurance or deductible, so it's completely free for the patients. It is a time-based code. However, there is no requirement to sit with the patient and fill out individual forms. In fact, you'd really only want to do that if everybody that the patient wanted to include in the discussion, including their healthcare proxy, was present at that time. But typically we find that that's usually in a home setting. So the best value here is to go through what the advance directive is, why it is important, what some of the goals are, what the patient should be doing and thinking about. There are some resources that we have in the back which are really good about educating clinicians on how to have that conversation, as well as providing some free forms that can be printed and given to the patient to fill out when they get home. Reimbursement is fairly good for a 16 to 30 minute conversation. In New Jersey, the average reimbursement is $92 for that conversation. There's a bit of a follow-up after the patient leaves, though. Medicare is looking for you to coordinate with the patient to bring their completed form back where they have designated a healthcare proxy, so that you have a copy of it and you can verify and then follow up with any questions that the patient may have had while filling that out. Some information about transitional care management. Contact needs to be made within 2 days of discharge. There is a face-to-face requirement. Depending on the complexity, it's got to be in the first week or the first 2 weeks. And then there's an ongoing non-face-to-face component, which is meant to help the patient coordinate their care, make sure that they've got the resources and access to any counseling or treatment options that they need in order to make the transition of their discharge successful. There is a component that must be furnished by physicians and non-physician practitioners, and only some of it can be provided by clinical staff, so just be aware of that. But the reimbursement does change to reflect the fact that there's a good portion that's required by physician and NPPs, so that's $182 over the 30 days following discharge. So CCM is meant to address chronic conditions. The current requirement is that a patient needs to have 2 or more. Those conditions need to expect to be lasted 12 months or greater, and they've got to pose a significant risk to harm to the patient. There's also a component that has to be delivered by physician and non-physician practitioners, which is 15 minutes, and then the 20 minutes can be done by clinical staff time with physician of a supervision, directed by a physician. Consent's required. It can only be delivered by one provider at a time, and then the ongoing monthly reimbursement is about $45 for simple CCM services in New Jersey. One point of note is that Medicare is coming out with a derivative chronic care management program where it's just one condition that's serious. It's usually an HCC condition, or at least one of the sets of HCC conditions, and that's going to be called PCM. That's going to start on the 1st of 2020. There's a link to that later in this deck. So behavioral health, like I said, is very similar to chronic care management, but with the exception that it is for behavioral and mental issues. There is an escalated complex portion where you involve the use of a psychiatrist to help with the patient's care. That's called collaboration care model, COCM. There are different billing codes. This is also 20 minutes of clinical time, 15 minutes of physician or NPP time. And it's very similar in that a patient's care plan needs to be documented, coordinated, and tracked. The reimbursement for standard BHI is $53, and then the more complex, $142, and that's recurrent monthly by patient. So very quickly, when we saw in the HRA taking social history, in particular, diet, exercise, weight loss, fall risk, tobacco use, that's meant to try to support population health initiatives. Those are the ones that CMS has identified. They are integral components of the annual wellness visit. You'll see nutrition, physical activity, weight loss, fall risk, tobacco use referenced in numerous places when you're looking at AWV documentation. And the goal here is to educate and to provide resources and self-management, self-help items to make small changes in behavior across large portions of the patient population with the expectation that'll make a bigger difference as an outcome versus big differences in a smaller portion of the population. So really it's providing an AWV to all Medicare patients, risk stratifying that population to identify those that would benefit, coordinating the delivery of resources and care, and then recording and documenting that you did that. So I'll just, because it's fairly cumbersome to read through, I'll give you an example. So if you have a grossly obese patient, and let's say you're going to risk stratify them by saying if their BMI is 40 or greater, you've got a specific action plan and resources that you're going to give them, and you can follow up with them through something like CCM services, but you're going to implement a standard operating procedure that says anybody that comes in with a BMI over 40, we do X. And NIA, National Institute on Aging, helps support that by creating free booklets with self-help resources, with action plans, with ways that patients can change their behavior and address some of their risk. Also all free. You can order them online. There are links to that in the back. And I would definitely take advantage of that since they're well thought out, they're well printed, they're in full color, they're easy to see. There's embedded action plans, and most importantly, just by providing it and having a quick discussion with the patient, you're compliant and you can document you gave them that publication, and that you're going to follow up, and you know that what you did there was meeting the requirement. We talked briefly about the quality payment program support from Medicare, from Medicare's AWVs. AWVs easily address 11 to 12 of the MIPS quality measures directly. Some of them are high priority. It'll also go to improvement activities. And the important thing is, if you're not reporting MIPS now, you definitely want to. It's tough if you're a practice with over 16 clinicians, because you've now got to have 70% data completeness in 2020, which means for a lot of these, you've got to report on at least 70% of your active patient base that you saw, or you won't get any credit for the category. So if you only saw 50% and it was a quality metric that was applicable to every patient, and you only reported it on 50%, you will not get any credit. I think you get 1 point actually for that quality measure. So annual wellness visits definitely help support that. HEC risk adjustment, also as you're going through, this is a good time if you're if you have Medicare Advantage contracted rates where you're under capitation, and your HCC conditions by patient reset every year, annual wellness visits are great to leverage to address renewing them annually and making sure that you have no gaps. So let's get just a little bit into some examples of revenue opportunity. And I'll first say that this is illustrative. It's typically not something you're going to see as many things, but I'm trying to convey what could be a typical scenario. They're not all associated with the annual wellness visit, but as you'll see, the annual wellness visit is what drives identification of these items. And then depending on your capacity and capability to deliver them, you've got a lot of options to improve patient care and drive new revenue. So we picked Mary as an example. We gave her a fairly young age for Medicare, so 71. She's got some typical chronic illnesses, and whether it's smoking or drinking or potential depression, generally you see people score a little bit right over thresholds on some of these things, and in order to keep them from getting worse or going past into a clinical diagnosis or something like alcoholism or minor or major depression, there's these brief interventions, referral for treatments, or behavioral health counseling that Medicare promotes that can be delivered quickly and easily based off of standardized screeners to help address that need for patients. So in this example, we identified mild cognitive impairment and depression. Those would come from an annual wellness visit because you need to be doing something like giving a mini cog or some kind of depression assessment and cognitive assessment. So then we can run a neurocognitive assessment on top of that concludes, oh, it's early stage Alzheimer's. We definitely want to deliver advanced care planning because she has not had that. And due to her chronic illnesses, she's entitled to CBD counseling. And because she's drinking 2 to 3 drinks a day, she's eligible for a review of her alcohol use. You can enroll her in CCM because she's got 2 or more chronic conditions. You can enroll her in BHI because she's got identified mild depression. And the cognitive one is interesting because where people do start to get identified with impairment, Medicare's got a separate cognitive care planning code that takes about an hour to an hour and a half in its entirety. It reimburses very well, and they're looking for you to do something similar to an action plan and treatment options, but that really then would support them getting into a BHI program, and then the work that you did to create how they're going to be treated and what the follow-up that's going to be required can then be monitored and managed on a monthly basis through BHI. So some of these reimbursements here, they're average reimbursements, I think, for Northern New Jersey as an example. But this is a completely possible scenario from a single outcome. This would be over 2 visits, just FYI, because the cognitive care planning can't be delivered on the same day as the annual wellness visit. But it shows how the annual wellness visit is a framework and drives additional value. The point, though, here is over the $900 on the visit outcome, we've got to understand that 2.5 hours or the minimum expected time for a physician or an MPP to support this. It also doesn't reflect the approximate $1,100 over the next 11 months for the combined CCM and BHI program. So one thing that we see is that annual wellness visits are not delivered to as many patients as Medicare is targeting. And the reason is that generally practices hit some common roadblocks. So there's a general, excuse me, there's a general lack of knowledge about what the annual wellness visit is, why it's important, how it can be delivered. It is difficult to identify sometimes the patients that it's applicable to, communicate, market, and schedule patients to come in for it. The visits are a bit complex due to the compliance requirements. And generally speaking, EHR systems don't support delivering annual wellness visits very well. I think that'll eventually change and become a little bit easier. Some EHRs have templates that you can add, but none of them are fully integrated into a workflow the way that you would expect if you're delivering a program that's supposed to be to 70–80% of your Medicare population. The good news is all of these are addressable, and they can be fixed, and you obviously can be successful. There's a recommendation typically on how to do that. There's a couple important key parts. Definitely need to designate a single champion within the organization that's going to move the annual wellness forward, adoption forward. Leverage what people have already done. There are tons of resources on toolkits. You can learn and engage with other practices that have done it. We know some people that have done swaps with clinicians to go and see how it can work in a mature practice that's been doing it for a while. You definitely want to prepare before you implement the service. It's not one of those things that you could just easily flip on and expect it's going to work smoothly. So there's some training. You want to get screeners that you're going to use integrated into the practice workflow when they need to be delivered. There's some learning around advanced care planning. And then things like just interventional services. So what happens when somebody's abusing alcohol? What do you do? The nice thing is there's also references for that. Usually there's a framework like the 5 A's that can be downloaded and laminated onto a sheet that helps not only have the discussion, but is a compliant form for documenting what that interaction with the patient was. It can't happen in a black box. You definitely are going to need to involve other people in the practice managers, IT, anybody in billing, because there's some compliance items there. You want to make patients aware that it's a free service and it's there to help them. And then generally, I think the recommendation is start with just the annual wellness visit. And then as that is running smoothly, you can expand into other areas like the brief interventions, the advanced care planning, stuff like CCM. And then once you're in more of a mature state, you can even be opportunistic where you're giving it to patients in the waiting room. And unlike commercial insurance, you can mix Medicare preventative services and E&M services together with a modifier, and they'll pay them both. And then your other option is to consider working with a vendor who's got experience in this, and they range anywhere from companies that'll come in and advise you on how to set it up on your own to technology-driven healthcare partners that will integrate with your EHR and provide tablets and other mechanisms to do automatic report generation and compliant billing. There's no way to say what is going to be best fit. I think that's an individual choice. There's some benefits of working with partners. There's some benefits of a homegrown solution. I think that the two things to consider, though, are compliance if you're going to do it on your own. Use existing toolkits and follow them. And the second is what is your time to deliver and how long is it going to take you? So while you may pay a little bit to work with a vendor or an advisor, that may pale in comparison to the number that you can do, as well as what the resources and overhead that's required to deliver it on your own. So that might be clinician time. It might be taking up rooms for long periods of time. And then I would just say, if you are going to work with anybody, make sure that they get the data back into your EHR, because that's where it needs to live. It's your data. You're only going to get credit for it if it's in there. I touched on this briefly, but be opportunistic when you hit the maturity level. Here's just an example of all the other services that are provided on the same date of service as an annual wellness visit. And you can see almost about half the time, it's an office or an E&M visit. So people are definitely combining them, and they're definitely working with patients as they come in for an E&M visit, and as they identify that they're eligible for an annual wellness visit, they're giving it to them. Here are some examples. They're for reference. You've got a copy of the slides of what Medicare is typically looking for when they say things like a personalized preventative service plan with a 5 to 10 year screening schedule, or lifestyle fitness risk factor and self-improving management items that you're looking to convey. These are some examples of that. There are some provider plans that go through how to address risk factors and conditions. And Medicare is pretty specific in that they want a lot picked up. Primary, secondary, or tertiary preventative interventions are recommended. There's a lot to go through. And so this is an example of how you can compliantly at least document and code what you're doing. And the nice thing is, if you're using an automated system, whether it's in your EHR or through a third party, definitely look to make sure that the coding and the quality metric reporting is automatically identified based on the outcome of the encounter. Because this is, again, is the only way you're going to get credit for things like high priority MIPS reporting for all of the things that are coming out of the annual wellness visit. And then I touched on industry standard screeners. I would use them, for example, PHQ-9 for depression and audit, as there's no question over the consistency or validity of them. They're validated rating scales, so it's very clear if we're going to, if you need to use them to support, if you need to use them to support medical necessity. I narrowed this down to just what we have found and had feedback on as the most valuable resources. So what we're looking here really is what's the best way to learn more about the annual wellness visit? What's the Medicare preventative services list? What's the kind of checklist that I should use? Give me some examples of health risk assessments, of annual wellness visit toolkits, so I'm not starting over from scratch. And even if you're doing annual wellness visits now, it would not hurt to look at some of these. They're either generally nonprofit organizations or other government agencies that we found have a really good handle on the way to position the annual wellness visit and what can come out of that. One of those examples is in Orange County Healthy Aging Initiative. This is a great resource. I'd recommend taking a look at it. Just one thing, I know Bree's going to come up with some questions that you've had. If you don't get your question answered, or if you think of any after, you can always send them to the email here, and we'll look to get back to you in a short amount of time.
Okay, thank you. So I'm now going to read the questions from the question box. If anyone has any additional questions they'd like to ask, please type them in the question box located on the right of your screen now. So the one question in here is, I work for an oncologist. Some patients have on occasion mentioned that they have only been seeing our MD. It is most likely due to our oncologist does a lot of follow-up screenings. Secondly, the patient avoids having to pay another copay, coinsurance to another MD. How are we affected with regards to the quality metrics? Although we do most screenings, we don't screen for other preventative components like high cholesterol. Please advise.
So a couple of things on quality metrics. So Medicare has published an Excel document, which is really useful, that has every measured incentive program quality metric in there. There's hundreds of them, and there's a lot of columns, and you can pick your type of practice. So you'd pick oncology, and you'd say, only show me the ones that are applicable to oncology. And then you can go in and you can say, depending on how you're reporting them, whether you're reporting them through the web interface or through claims, you can narrow down the set which really is only applicable to you and your practice and your specialty. On top, there's a very good chance you're going to end up with a lot more than 6. On the quality side, Medicare is only picking up your top 6. You get extra credit for high priority ones, but don't feel like you're going to be out in the cold because somebody else is reporting them, or you're not getting enough variation. I would worry more about data completeness making sure that any quality metric that is applicable to anybody that walks in your door, you're capturing. So you'd have to look at those filters. What are the outcomes? What do you want to target? And then the recommendation would be to implement some kind of standardized screening or assessment tool for patients as they come in. And depending on the quality metrics, some of them could be every visit, but generally, mostly speaking, they're specific encounter-based or just once a year. And that's really the best way to do it. And if you need a link to that Excel document, just send an email to the Ask a CarePoint MD, and I'll forward a link back to you with the Excel document that you can then use to create your approach.
Thank you, Mark. There doesn't seem to be any questions at this time. Just give a couple more seconds for any last-minute ones to come through. Alrighty, so if there are no further questions for the day, then we can wrap this up. Once again, thank you for a great presentation, Mark, and the presentation slides will be emailed to all participants and will be available on the website for members only, as well as we will be sending a quick survey because your feedback is important to us. If you have any additional questions, please reach out to the presenters directly. Thank you again for attending, and thank you for the presentation. I hope you all have a great day.
Thank you, Bree.